Are you ready
And
for me to start then?
yes, Dr. Newman. Dr. New, you can start. Sorry.
All right, thank you. Hi, everyone. So I'm going to present a case from Johns Hopkins All Children's. Next slide, please. This is a 15-year-old female with hemoglobin SS. She has a past medical history of being on hydroxyurea since she was 8 years of age. It was started at the time because she had a couple of conditional TCDs. They normalized once she was therapeutic on hydroxyurea. In 2022, she actually was switched from hydroxyurea to partial exchanges because she had what was thought to be a TIA event, and at the time had an MRI-MRA, which was significant for showing some right internal carotid artery stenosis. She was followed by neurosurgery, and they obtained an angiogram and determined that her stenosis was not deemed hemodynamically significant. And therefore, since her TCDs at the time were normal, we transitioned her back onto hydroxyurea. She does have a past medical history of strep pneumobacteremia in 2011, for which she's been on penicillin prophylaxis. About a month after we stopped her partial exchanges, she started having a little bit more frequent pain, but she was on a good dose of 28 milligrams per kilo of hydroxyurea. Her baseline hemoglobin was between 7.5 and 8. And her fetal hemoglobin max 3 years into therapy was around 18.8%, and more recently was around 10.6%. But had a couple of transfusions in the interim. Just socially, she's a cheerleader, and her position is a flyer. So she's one of the cheerleading squad that gets thrown in the air. Next slide. So she presented in February, early February, with a 6-day history of blurry vision in her right eye. We advised her when her mom called to send her to our emergency center and requested that she have an urgent retinal specialist exam. She was seen by ophthalmology in our EC, and they diagnosed her with mild vitreous hemorrhage of her right eye, and her left eye was noted as being normal. We later found out that this was not a retinal specialist. We thought that she had seen a retinal specialist at the time. They wrote an exam finding that her vision in her right eye was 20/50 and her left eye vision was 20/25. They recommended that she follow up with an outpatient retinal specialist within 2 weeks and to come back sooner if she had symptoms that got worse. They did do a brain MRI, a fast scan without contrast, showed no evidence of infarct or hemorrhage. They did note that the exam, although not tailored for the orbits, did not show definite abnormality. Next slide. 8 days later, she complained of having complete loss of vision in her right eye. We again advised her to go to our emergency center. As full disclosure, I was actually off. My husband was having surgery, but in conversation with my nurse practitioner, we realized that she was coming in. So I asked her to reach out to our hematology team and let them know to treat this like a stroke, regardless of what her imaging would show. We were planning for urgent red cell apheresis. By the time the message got to our hematologist, the patient was already in the MRI scanner for brain MRI of the orbits with and without, brain MRI and orbits with and without contrast, as well as an MRI of the brain. And so our inpatient provider was working with our ICU so that once she got there, she could get exchange. They noted no acute changes or findings on her MRIs. She had also had a head CT before they reached out to my covering provider. And following the scans, they sent her to the ICU for what we thought was going to be red cell apheresis. But there was about a lapse of at least 4 hours from the time that she presented to our emergency center, had all the scans, and got to our ICU. Next slide. So they had placed two 18-gauge IVs. And so initially we thought she had large enough bore IVs placed that they might be able to try to do the red cell exchange peripherally. We have an outside apheresis team that comes to our center to do emergent as well as our scheduled pheresis. So they came to the bedside. They were there by the time she arrived to the ICU. The apheresis machine was unable to draw and return, and therefore the apheresis team informed the ICU that she needed central access placement. Our ICU provider informed them that it was going to be at least 1 to 2 hours because they were in the midst of change of shift or sign out for the providers. And so they were not going to be able to return that evening to do the exchange. In conversation between the ICU and our hematologist, they recommended giving her a simple transfusion so that she could get a central line placed so that she could get the apheresis the next morning. However, there was a miscommunication between our hematology team and ICU. And so central line placement did not occur until the following morning when they realized that we still wanted to do the exchange. Next slide. So she underwent a single volume red cell exchange. She tolerated it without event. Ophthalmology was able to come and see her following her exchange. Her vision in her right eye at that time was 20/300, and her vision in her left eye was 20/40. The ophthalmologist that came to see her inpatient was also not a retinal specialist. We don't have someone on staff that's a retinal specialist. There were no other clinical symptoms. She had a normal neuro exam throughout the entire time, and she was able to be discharged a few days later. Next slide. So since that time, we saw her in our clinic, and we actually recommended to the family to have her come back in and get a port placed so that she could start on monthly red cell apheresis to try to keep her hemoglobin S suppressed. She does have some alloantibody formation. She has anti-Cal, Cal1, and today we were told she also now has anti-E, anti-Big E. She has seen three separate ophthalmologists without seeing a retinal specialist. However, this week we did find out her mother was able to travel to Orlando for a retinal specialist, which is about 2 hours away. There is a retinal specialist in Tampa, which is a bit closer. They will see her now on follow-up, but they advised her mother that they would not be able to treat her if there was anything treatable because she's only 15. This particular retinal specialist sees patients 15 and older, so thankfully she's old enough that they'll see her. So I guess our questions were any indication to keep her on hydroxyurea as opposed to resuming red cell apheresis transfusions, and any further imaging or workup recommended to evaluate her. And just of note that her mom does actually have lupus. She's not had any neurologic symptoms from that, but just knowing her family history, we'll probably work her up for that as well, especially in light of the new antibody formation.
Yeah, thank you for such an interesting case. Definitely very interesting. Any comments from the audience?
Hi, Tamara.
Hi.
Very interesting case, and I don't know, we're seeing a little bit more ophthalmology complications. I think I may have missed it. Did this kid just have retinopathy, or did she have a central artery occlusion?
So you haven't missed it. She has not. So she saw a retinal specialist in Orlando. I don't have the report from them yet to know whether or not she has the central retinal artery occlusion. I suspect that she does, That was what I suspected when she came in with, with the loss of vision. But I did not realize that she was not able to get a retinal specialist to see her. And in the interim between those 8 days in between events, her mother tried going to a couple of different ophthalmologists that we have in our area. And the retinal specialists that were in our area either said she was too young and they couldn't treat her, or they didn't take her insurance. And so we've been kind of stuck back and forth with this. So she actually went to the emergency center at Tampa in order for them to get an ophthalmologist that could see her, to get her fast tracked to be seen by the one adult retinal specialist in the Tampa region that will see patients as young as 15.
Okay. I think also the point you made about mother having lupus, if we don't have a clear-cut central artery thrombus, which can happen with, sickle cell, more commonly in the older patients with SC, I would do like antiphospholipid antibodies. Add antiphospholipid antibodies to see if that's contributing to it.
Okay.
And until you clarify, if it's a central artery occlusion, then I think most of us would treat it as a stroke. Either way, she stays on transfusions until you clarify if you're dealing with just a retinopathy versus a bigger arterial occlusion. And I think the debate on keeping the patient on hydroxyurea can go 50-50 depending on if we polled all of us, maybe half will keep and half would not. I am more inclined to keep because we know that, especially since she has early immunization, and we are not sure about how consistently long a transfused unit lives. Some patients, by the time they come back in 4 weeks, the hemoglobin is really trending down and the retics are already up. I think to encourage the F cells and reticulocytes having fetal distribution, there really is no harm in keeping her on I don't think there's any more harm than she's already been to keep her on the hydroxyurea. And just my thoughts. Oxbryta, I'll say take off because we don't know, but hydroxyurea, there's no harm.
Thank you, Emma.
I had a question about just ophthalmology expertise. I mean, don't you have ophthalmologists that take care of retinopathy of prematurity?
I believe so. So I'm relatively new here. Well, I say I'm relatively new here. I've been here a year now, and this is the first patient that I encountered with this. And so I naively thought, I send you to the EC and say you need an urgent retinal specialist, that's what was going to happen. And again, as a disclaimer, not that it's an excuse, but I was home,
Right.
With my husband for surgery. So I thought that, the message would be translated. And I think everybody tried. I don't think any of us realized that the person that responded was not going to be a retinal specialist and would not have a direct method to getting a retinal specialist sooner than later.
Yeah, because I mean, I think that a general ophthalmologist should be able to tell sickle cell retinopathy with hemorrhage from a central arterial occlusion. I mean, I think that that's within the scope, even for pediatrics. Maybe not all the treatment.
Right.
I mean, for central retina occlusion, if it's fast enough, they'll still PA to the vessel. That's someone who's a central center. For adults. At a fluorescein angiogram.
Say that again. I'm sorry, I missed that last part.
Like a fluorescein angiogram would be a typical part of the evaluation for someone that cell retinopathy or the occlusion, which requires specialized equipment, but that's typically that would be done as part of the evaluation, even in a non-emergent setting.
Yeah, and so I think I believe that's what they were planning to do when she went to Orlando to see the retinal specialist. I'm still waiting on their report, though.
Great. Okay, thank you.
Thank you.
Hey, it's Carrie, sickle cell nurse practitioner at All Children's. So I do know our ophthalmologists will diagnose the retinopathy, but they send to a specialist for treatment. But and based we don't, like Tamara said, we don't have the report from Orlando, but mom said when we saw her this week that the retinal specialist told her that it didn't seem like she had retinopathy any worse than any other typical sickle cell patient they see. So I don't think that was what that he was saying it was. I didn't see a report, but mom said that's what he said.
Yeah, and she wasn't able to tell us about the whether or not she had central retinal artery occlusion, but also
Right.
yes, we're presuming that maybe that's not the case because but I'm not sure that mom would be able to remember that exactly. So she thought we would have the report when we saw her.
Any other
Thanks,
questions?
everyone.
Comments?
Yes. Mhm.
Hey, Dr. Lanzi, and that is a nice presentation. I also have just a comment that doesn't, appear to be a typical, sickle cell presentation, the way the girl presented. So I think all the banks on the ophthalmology, opinion, and, it's been 7-8 days or longer, right? And she hasn't had any other treatment, ophthalmologically except for the exchange transfusions. And it seems like the vision hasn't improved, which I would have thought that any complication from sickle cell disease would have improved. So yeah, I think it'd be reasonable to continue the hydroxyurea. There should be no point in discontinuing that.
Thank you.
Thank you, Dr. Imran. Any other questions, comments? Thank you, Dr. Neil.
All right, thank you.
So we can move on to our didactic by Dr. Patel.
Hello, good evening, everybody. Let me share my screen. All right. Good evening, everybody. My name is Niren Patel, and I am the laboratory director and senior research scientist at Titus Heisman Hemoglobinopathy Lab, Center for Blood Disorders at Augusta University. I work under the directorship of Dr. Abdullah Kutlar, and I'm going to talk about our newborn screening program and the laboratory diagnostic methods that we use for common hemoglobinopathies. We are part of the newborn screening program where in the state, Georgia State does the initial run screening, and then of those who are hemoglobinopathy positive will come to us for confirmation. We also act as a referral lab for many different institutions. Today, our objective will be to understand the pathophysiology of hemoglobinopathies, to recognize important and expected test results in hemoglobinopathies and thalassemias, to understand different testing methodologies, and to combine different test results to make meaningful diagnosis of this complex disease. As we are all aware, hemoglobin is a protein in a red blood cell and consists of 2 alphas and 2 beta subunits or beta-like subunits, making a tetramer. And it also has 4 heme subunits per molecule. Here is the structure of the hemoglobin. As we can see, 2 alpha chains and 2 beta chains are nicely attached to each other to form a very nice globular structure. But because these chains are quite large, 141 amino acids per alpha and 146 amino acids per beta chain, we can all assume that every amino acid can be mutated, and hence we can see a lot of different hemoglobinopathies and its combination. To understand the structure of this chain is very important, just because different amino acids on these chains have different functionality. For example, on this alpha chain structure, the red amino acids are the heme contact points. The green amino acids are the alpha 1 beta 2 beta 1 contact points, and the black amino acids forms the alpha 1 beta 2 contact points. So these are important just because of the location. So if there can be mutation on one of the surface amino acids, and classical example is sickle cell, the mutation can be near the heme pocket, resulting in hemolytic anemias or methemoglobinemia. It can also be at the alpha 1 beta, the interchain contact points. The alpha 1 beta 1 contact point disruption typically leads to unstable hemoglobins, and the alpha 1 beta 2 contact point disruption typically leads to altered oxygen affinities. There is a hemoglobin, the two chromosomes involved in production of the hemoglobin proteins. The chromosome 16 is the alpha genes, and chromosome 11 has the non-alpha genes. And as we all are aware that during the fetal life, predominantly it is hemoglobin F, which after birth starts switching into hemoglobin A. And again, when we are diagnosing a case of hemoglobinopathies, age of the patient plays a very important role, just to understand how the switching is working. So hemoglobinopathy can result because of two things. It can be a qualitative or a quantitative defect. If it's a qualitative defect, it will produce abnormal protein. There can be structural change. There can be a substitution, addition, deletion of one or more amino acids. And there are many different qualitative defects known. The most common ones are hemoglobin S, C, E, T, O, and the list keeps going on. Today, we know about 1,871 mutations that are entered into the globin gene server, the hemoglobin variant database. Good thing is most of these are clinically silent. Of course, the most common one is a sickle mutation. Or hemoglobinopathy also can result as because of gene burnout. Again, these are genetically inherited. It will produce normal protein, but in lesser quantities. If the beta chain production is disrupted, then it will lead to beta thalassemias. There can be two types of beta thalassemias, beta 0 and beta plus, meaning in beta 0, the hemoglobin, the gene loses its ability to produce any protein at all, versus in beta plus, there will be some protein production continuing. The alpha thalassemia also can be a result because of the disruption of the alpha chain production. Again, in both these cases, the pathogenesis is because of the free extra protein that is there. In case of beta thalassemia, it's the free alpha subunits, and in case of alpha thalassemia, it's the free beta subunits. There can also be delta beta thalassemia, resulting in the deletion of delta and beta genes. And there is another condition known as HPFH, hereditary persistence of fetal hemoglobin, and this continues the expression of gamma genes at higher level in adult life. So this is another larger beta gene deletion. So like I mentioned, the pathophysiology in normal human being, the alpha and beta are equal quantity, hence they form the tetramers, and there is no excess alpha or beta chains. Versus in alpha thalassemia, there are excess beta chains which will form tetramer to form hemoglobin H. Similarly, in alpha thalassemia, during early stages of life, there are excess gamma chains which will lead to production of hemoglobin bars. And in beta thalassemia, there will be excess alpha chains which combine together to form a tetramer, and they are very insoluble, and that's why these RBCs are readily destructed in marrow and spleen. For the laboratory diagnosis that we use, the common hematologic evaluation is the first step. Most hemoglobin disorders are noted on the CBCs, the red count, the peripheral smear, Heinz body, all those kind of leads to suspicion of hemoglobinopathy, after which the sample is sent to a laboratory where we have the ability to do isoelectric focusing on an agarose gel, which gives us a qualitative indication of whether hemoglobin is normal or abnormal. HPLC is a gold standard. And there are two types of HPLC that we use. One is the cation exchange HPLC, and reverse phase HPLC. The cation exchange is used for the quantitation of hemoglobin fragments and the separation of different hemoglobin fragments. And the reverse phase HPLC, we use it to look at the globin chains. There are some other special tests available, the hemoglobin stability test and the oxygen affinity test are also available. And more importantly, the molecular methods could be PCR amplification and gene sequencing, or gap PCRs for detection of deletions. Chromatography is a technique of separating the mixtures into their components. And this is the primary technique that we use. And it has kind of replaced the classical gels that we used to see in past. And most hospitals or most institutions, they use HPLC to separate the hemoglobins. And because the advantage is to accurately identify, analyze, and quantitate these different hemoglobin fragments. Over here, there are several commercial HPLC units available, but we have our own lab developed method, and we use the HPLC unit from Waters. The advantages to our system is that we have a very low background, and we are able to accurately quantitate different hemoglobin fragments because of that. We do have a very good separation of hemoglobin F and hemoglobin A1C, and we also are able to accurately measure hemoglobin A2, because in most systems, hemoglobin A2 are contaminated with hemoglobin S1. And these are essential because most systems, they run the hemoglobins fairly fast, and hence the separation may not occur when we run the hemoglobins faster. But on our system, we have the ability to separate different variants because we run it for a longer run. So here is our control that we run daily on our system. As we can see, we run our samples for more than an hour, 65 minutes to be specific, and hence that's the reason why we are able to get such a good background as well as very good separation of different hemoglobin peaks. The reverse phase HPLC helps in a way that it separates the globin chains. So now we are not looking at the hemoglobin as a tetramer, but we are looking at the hemoglobin as globin chains. And this is essential to identify what globin chain is affected. And it is also helpful in certain thalassemias and HPFH. The molecular methods available for alpha thalassemias are PCR and reverse hybridization assay. The gap PCR assays are available, as well as alpha globin gene sequencing. For beta thalassemia, we use beta globin gene sequencing because predominantly 95% of beta thalassemia are point mutations. And after that, we will go to the beta globin duplication or deletion testing by gap PCRs. And for variant hemoglobins, after running it on reverse phase HPLC, we typically look at the globin gene sequencing. It can be a mixture of alpha, beta, gamma, and delta genes. The gap PCR techniques are very useful for certain larger deletions like alpha thal deletions, certain beta thal deletions, also even in case of duplications, hemoglobin Lapore, which is a delta beta fusion, and hemoglobin H and the HPFH, hereditary persistent of fetal hemoglobin. However, the limitation is that we need to know the breakpoint before we can design a gap PCR assay. So that's the limitation of this assay. DNA sequencing is kind of gold standard in identifying the variants. So it's a process of determining the precise order of nucleotide within a DNA molecule. Sanger sequencing method is what we have been using. It uses the di-deoxynucleotides along with the deoxynucleotides, which enables chain termination, and hence we are able to identify every sequence, every nucleotide in the DNA sequence. Here is the pictorial of how the chain reaction works in case of DNA sequencing. As we can see, as soon as the DDNTP attaches to the chain, it stops the elongation, and it is tagged with a fluorochrome. Hence, it's able to be detected by the laser. And different peaks are eluted in form of a chromatogram in different colors, and that's how we are able to identify each nucleotide. Here is our overview of evaluation of the hemoglobinopathy cases in our lab. First and foremost, we always run HPLC. So based on the HPLC, we can see whether there is a variant hemoglobin present or not. If it's a variant hemoglobin present, then we will do the reverse phase. After the reverse phase, we are able to identify which chain is affected, and based on that, we will do the sequencing of that particular chain. And if a normal phenotype is observed, then we look at hemoglobin A2 values. The hemoglobin A2 values, if it's high, then it's suggestive of beta thalassemia. And like I mentioned, most beta thalassemias are SNP mutations, hence we do the sequencing first. If the sequencing reveals no mutation, then we go for the beta thalassemia deletion. However, we do not have primers for every beta thalassemia deletion, but we are able to identify a lot of these deletions. And if it's a normal phenotype with low or normal hemoglobin A2, then we screen for alpha thalassemia. Again, our reverse hybridization method is able to screen for 21 different mutations and deletions all at the same time, which helps because we don't have to run gap PCRs for each and every deletion. If on that assay, if we do not detect anything, then we look at the CBCs. If it's low MC with normal RDW, then we will screen for the alpha thalassemia SNP mutations. How they are very rare mutations that can lead to thalassemia-like picture, and we don't want to miss on those. But if it's low MCV with high RDW, which may suggest of iron deficiency, then we don't take any further action until and unless the physician suggests otherwise. We are on HPLC, if there is high hemoglobin F for the age of the patient, then we run the test for HbFH. We only have current testing for HbFH1 and HbFH2 deletions. The other HbFH deletions cannot be identified by these methods, but those HbFH1 and 2 are the most common two deletions leading to HbFH. And also on HPLC, we are able to detect another hemoglobin, another fusion chain, which is hemoglobin lipor, and we confirm it with a gap PCR. And once the gap PCR identifies that hemoglobin lipor, we'll do the DNA sequencing to identify the type of hemoglobin lipor. So this is a general protocol that we follow in our lab. Here are some of the hemoglobin variants that we routinely see on our HPLCs and how we are able to identify and differentiate between these hemoglobins. So the first picture on the left upper hand is the ASFC control. All the peaks are fairly separate, very well separated, with hemoglobin C eluting last, hemoglobin S, hemoglobin A2 in the middle, and then hemoglobin A and hemoglobin F in the very beginning. The second picture is of the normal hemoglobin. The third chromatogram is classical of hemoglobin AS straight, where both the hemoglobin A and hemoglobin S are expected to be in equal proportion. The fourth picture chromatogram is classical of hemoglobin SS, where we only see predominantly hemoglobin S with a little bit of hemoglobin A2 and some hemoglobin F. On the right-hand side, on the upper top, we see the chromatogram for hemoglobin AC, which is a C trait. Again, the hemoglobin A and C are in equal proportion. The next one is hemoglobin CC. This is, again, a newborn case where we are able to see a very high F and little hemoglobin C. Also present is a very short peak in the at about 2 minutes, which is suggestive that this baby also has alpha thalassemia, because that is hemoglobin bars. The second, on the right-hand side, the second last chromatogram is hemoglobin AE trait. AE trait, again, this is a newborn baby, which is probably having a lot of F, and then hemoglobin A and hemoglobin E. And the last one is hemoglobin EE. Again, the hemoglobin E and hemoglobin A2, they do not separate on our on cation exchange. And hence, if we see hemoglobin A2 values more than 6%, then we suspect hemoglobin E. Here are some of the hemoglobin variants that we have detected on our system. So now over here, in this case, we can see the presence of two chains, hemoglobin A, and then another chain which runs like hemoglobin S, but is not quite hemoglobin S. And as we can see, there is mismatch in the ratio also. And this is classical of alpha chain variant. So whenever there is alpha chain variant, the alpha chain pairs with all the different chains. So the alpha normal with beta normal will form hemoglobin A, and alpha abnormal with beta normal will form this variant peak. Same in the second case is we have presence of hemoglobin F and hemoglobin A as normal hemoglobins, and hence we are seeing two additional peaks which suggest of alpha chain variant. And in the third chromatogram, we can see three different hemoglobins which pairs with normal alpha chains, which is hemoglobin F, hemoglobin A, as well as hemoglobin S. And hence, we also see three different abnormal alpha peaks. So based on the HPLC alone, we are able to say whether it's an alpha chain variant or a beta chain variant. Here are the HPLCs, some HPLCs related to thalassemias. In the beta thalassemia, classical presentation is with high hemoglobin A2. So there will be hemoglobin A, high hemoglobin A2, and some hemoglobin F in the early stages. Again, the two peaks in the front one is hemoglobin F, and the second one is hemoglobin A1C. And this is what we are able to separate very well on our systems. The second chromatogram is a F-only picture, where this is a classical case of beta thalassemia major, where there is no production of the beta chains, and hence everything is just hemoglobin F. This one, the third chromatogram on the left-hand side is alpha thalassemia because of the presence of hemoglobin bars, which is very early in the stage. Because on this chromatogram, we can safely say that this is probably hemoglobin H, because most of the hemoglobin has converted from hemoglobin F into hemoglobin A, and there is some presence of hemoglobin F and a very low hemoglobin A2 value, which is classical of the 3-gene deletion or hemoglobin H disorder. On the right-hand side, we are looking at the S beta 0 and S beta plus chromatograms. The top one is the S beta plus, where we see hemoglobin F, hemoglobin S, and some production of hemoglobin A, but not quite as much as hemoglobin S. And this is how we distinguish between FAS, which is an AS trait, versus S beta plus thalassemia, where we will see some 15 to 17% production of hemoglobin F and a lot of production of hemoglobin S. And this case on the right-hand side, the second chromatogram is for the S beta 0 thalassemia, where the hemoglobin A is completely absent. So this is how we are able to identify S beta plus versus S beta 0 on chromatograms. These are some of the genetic gene analysis for the beta thalassemia mutation. The first one is a promoter -88 leading to beta plus thalassemia mutation. The second one is in the IVS2 region, 849th nucleotide, and that is a beta 0 type of thalassemia mutation. And there can be insert or a deletion can lead to frameshift mutation, which are very easy to pick because every peak after that will be a duplicated peak on sequencing. And sometimes the mutation will lead from amino acid into a stop codon, and hence this will represent as beta 0 thalassemia. Here are some of the case studies that I included just to kind of give you a picture of how each method coming together can work wonders. So first step on this case, we did the hemoglobin electrophoresis, the HPLC, and we found 26% hemoglobin F with hemoglobin S of 71% and A2 of 1.8, which is low. This can be and again, this is an adult, this is not a newborn baby, or it's the age of the patient was more than 1 year. So in this case, yes, this can happen if the patient is on hydroxyurea. We classically see somewhere between 20 to 30% response of hemoglobin F. But when we ran it on reverse phase, we observed the presence of alpha chains, the beta S chains, and the G gamma chains, but the A gamma chains were missing, which kind of leads to suspicion of A gamma delta beta 0 type of thalassemia. And we ran it on gap PCR. We confirmed with the gap PCR that the deletion was present. So that's why we are seeing hemoglobin S, but on one gene it's mutated for hemoglobin S. On the other gene, it's there's a larger deletion for the 34 KB deletion involving the A gamma, delta, and beta. And if you can see, the A2 values are also half just because of that, because the delta gene is also deleted. In this case, as we can see on the HPLCs, there are two proteins that are produced by the combination of alpha and beta, which is hemoglobin S and hemoglobin C. But at the same time, we do see two additional peaks that kind of indicates that there is something going on with the alpha chains as well, or the alpha genes as well. And when we ran it on reverse phase, again, we are able to identify the beta Cs, the beta S, the deltas, the alphas, and there is a little shouldering peak that comes after the alpha, which is the alpha abnormal gene, the alpha abnormal chain. Upon gene sequencing, when we sequence the alpha genes, we found the mutation on exon 1, codon 20 is stayed into proline, the hemoglobin Fulton trait, and on beta gene also we found two mutation for hemoglobin S and hemoglobin C. So this is a classical example where both the alpha and beta genes have mutations. This is a good example where we can miss something, and this is hemoglobin question bird. Hemoglobin question bird, as we can see on the normal HPLC, we only see hemoglobin A and hemoglobin A2 with very little hemoglobin F, but everything else looks normal. Even on reverse phase, we only are able to detect the two chains, which is alpha chains and the beta A chains, but there is no presence of abnormal hemoglobin. But upon sequencing, we did find a mutation on alpha 2 gene on exon 3, codon 131, to be hemoglobin question bird. Now, hemoglobin question bird is a very highly unstable hemoglobin, and hence, when we process blood to run it on HPLCs, all the unstable hemoglobin will be washed off, and that's why we are not able to detect it on the HPLCs. And we have to rely on genetic methods to kind of diagnose such cases. Here is the case where I was talking about for hemoglobin lipor, that it looks like a small peak, variant peak, along with hemoglobin F, hemoglobin A, and hemoglobin A2. But this one does not fit any classical presentation of a beta chain variant or alpha chain variant. For alpha chain variant, it is 2 less, and for a beta chain variant, again, it is 2 less, because we would expect A and the variant chain to be in equal proportion. And this is again confirmed with by the presence of an abnormal peak on the reverse phase HPLC, and we did the gap PCR analysis to identify the hemoglobin lipor. Once the gap PCR is done, we do sequence gene to identify the 3 different most common lipor mutations known. The lipor Washington, Boston, or hemoglobin lipor Boston, hemoglobin Baltimore, and lipor Holland. So I hope that this presentation kind of helps to understand the complexity of this testing, and how together different tests can bring like final diagnosis to the case.
Thank you, Dr. Patel. Any questions? Okay, thank you. And I think we finished a bit early today. So have a nice day, and we'll see you guys back next time. Thank you.
Thank you all.
Goodbye.
Thanks, bye.